Hello, my name is Paolo Gontero and I'm a urologist in Torino, Italy. There are clear signs on the horizon that the management of bladder cancer will be enriched by the introduction of urinary markers in clinical practice, particularly for surveillance of non-muscle invasive bladder cancer. And the availability of new promising tests, as documented by recent publications, along with their increasing need and new statements by recent EAU guidelines, strongly support this idea. In the 2019 version, EAU guidelines were quite strict in stating that no urine marker could replace cystoscopy in the follow-up of a non-muscle invasive bladder cancer. Urine cytology was the only accepted marker as an adjunct to cystoscopy. While it was acknowledged the lack of randomized studies supporting a reduction of the current scheme for follow-up cystoscopies, it was actually recognized the potential role of a urine marker to improve the performance of cystoscopy. And this was based on a randomized study showing improved detection of recurrent disease when cystoscopy was actually carried out with the knowledge of a positive urine test. And in that study, the test was represented by microsatellite analysis. Based on the evidence at that time, the 2019 guidelines view on urine biomarkers was that of an agent for cystoscopy and not as a substitute for the procedure. In the 2020 edition of the EAU guidelines, the view of a urine marker is extended to a tool that could potentially replace a cystoscopy and thus reduce the burden and invasiveness of the follow-up. A test able to effectively predict absence of tumor with a high negative predictive value would be particularly useful in clinical practice to serve this purpose. And in this context, the guidelines mention a number of recent studies on novel urine markers that have shown high negative predictive values in initial prospective studies, thus potentially supporting utility in clinical practice upon, obviously, confirmation of the results. There is no doubt that the currently recommended follow-up scheme for non-muscle invasive bladder cancer is burdened by the need of frequent cystoscopy, ranging from a minimum of 6 for low-risk disease up to 14 for high-risk disease at 5 years, with an individualized scheme falling in between the two for intermediate risk. Besides, lifelong follow-up is needed for high-risk disease, with further overload for healthcare systems. Notably, evidence supporting the most appropriate follow-up scheme is scarce, making the strength of this recommendation as weak as you can see. So, while we are currently bound to a follow-up scheme that has been adapted, taking into account the risk of progression of the disease, and is based more on expert opinion agreement rather than evidence, we acknowledge the clinical need to implement it by a less invasive methodology that can safely allow us to reduce the burden of follow-up. A urine biomarker could perfectly serve this purpose, and there are several molecules that appear as promising candidates. While further evidence is awaited, ideally in the setting of a randomized study comparing the currently recommended follow-up scheme with one where less frequent cystoscopy are alternated with urine biomarkers, we need to clarify something anyway. First, what are the minimal requirements we expect from a urine marker? And second, how can we position a urine marker in the flowchart of a follow-up of a non-muscle invasive bladder cancer? Here you can see an example of a flowchart showing how a urine biomarker could be integrated in the follow-up scheme of a non-muscle invasive bladder cancer to reduce the number of cystoscopy. A given urine marker could be assessed at any time of a planned follow-up cystoscopy, obviously following a previous negative cystoscopy. Assuming that a negative result has a very high probability to rule out recurrence disease, the cystoscopy could be safely omitted and delayed until the next one planned. Conversely, a positive test would prompt a follow-up cystoscopy, whose sensitivity, by the way, has been even shown to be improved by the knowledge of a positive urine marker. So, how can we translate this scheme in clinical practice? And what would be its impact? If we consider 100 high-risk non-muscle invasive bladder cancer within the first 2 years of follow-up, based on the current guideline recommendations, a burden of a total of 400 cystoscopies will have to be undertaken. And if we assume a recurrence rate at 1 year of 38%, and we assume that the cystoscopy has a 100% sensitivity, it will follow that a maximum of 38 patients will be diagnosed with a tumor recurrence. So, what would be the risk of delaying by 3 months the diagnosis of a bladder cancer, and the benefit in terms of reduction of the number of follow-up cystoscopies of alternating a urine marker to the 3-month cystoscopy scheme? This will depend upon not only the negative predictive value, that is the probability that a patient with a negative test truly has no disease, but also will depend from the sensitivity and the specificity of a given marker. Since the negative predictive value of a given marker reflects the disease prevalence, it follows that different markers with similar, very high negative predictive value may vary for their sensitivities and specificities. And this will translate into 3 possible clinical scenarios. A high sensitivity with a low specificity will result in a low number of missed tumors at the price of a limited number of avoided cystoscopies. In our hypothetical series of 100 high-grade tumors displaying 38 recurrences per year, there will be a benefit of 55 avoided cystoscopies at the price of 1 missed tumor. Conversely, a marker with a high negative predictive value, but with a low sensitivity and a high specificity, will display the maximum benefit in terms of avoided cystoscopies. It will be 179 avoided cystoscopies in this case. but also the highest price in terms of missed high-grade tumors. 4 tumors will be missed. The ideal scenario is number 3, when a marker with a high negative predictive values also has a high sensitivity and a high specificity. And here there will be a net benefit of avoiding 158 cystoscopy and missing only 2 high-grade tumors. So, an ideal marker to safely replace follow-up cystoscopy will have to combine not only a high negative predictive value, which is affected by the disease prevalence, but also a high sensitivity, which will guarantee that the patient with a negative test is unaffected, irrespective of the prevalence of the disease, and the high specificity that will allow for an effective reduction of cystoscopies by reduce the false positive results. In conclusion, while currently no urine marker beyond urine cytology has been validated in the follow-up of a non-muscle invasive bladder cancer, there is an urgent need to reduce the burden of cystoscopy, whose schedule is also not supported by a high degree of evidence. And the advent of promising new molecules with a high negative predictive value has raised interest from the guidelines to acknowledge their need in clinical practice and potential role upon confirmation of their results, of course. Optimal benefit of a urine marker in terms of an effective reduction of procedures while maintaining diagnostic yield can be achieved by a combination of a high negative predictive value, high sensitivity, or at least acceptable sensitivity, and acceptable high specificity. Ideally, the safety of a change in the current follow-up scheme will have to be proven in the setting of a randomized study showing the validity of alternating a urine biomarker with cystoscopy. Thank you for your attention.